Our in first session we have TKR as topic, and I invite Dr. Ritesh Roy and fellow Dr. Payal for this session. Over to you, Dr. Ritesh.
Good evening, everyone. And so basically, we will be discussing about it's a case discussion on total knee replacements. So we will be talking about the anesthesia plan and the regional anesthesia plan and about the how to go about it. So with me, Dr. Payal, she is my fellow, exam going fellow. Her tenure got over a few last month. So right now she is busy in other hospital and preparing for the exam. So Payal, can you just log in?
Uh,
Payal, you are there?
yes, sir.
Yeah,
Good
Payal.
evening.
Yeah.
Yeah.
So Payal, please present your case.
Yes, sir. Is it visible now, sir?
Yeah, it's visible.
Yeah, it's visible.
So, good evening, everyone. I'm Dr. Payal, AORA Fellow from Care Hospitals, Bhubaneswar. So, I'll be presenting the first case discussion of the evening. My mentors are Dr. Ritesh Roy, sir, and Dr. Gaurav Agarwal, sir. Now, coming to the case, a 72-year-old female from Mrs. S from Puri, Odisha, presented with pain. Excuse me, sir. I'll start again. A 72-year-old female, Mrs. S from Puri, Odisha, presented with pain in both the knees since last 2 years. The pain was continuous type, increasing as the day progressed. She also had difficulty in standing and performing her daily activities due to the pain. However, she gives no history of chest pain or dyspnea, even on climbing a flight of stairs at her own pace. She's a known hypertensive, well controlled since the last 10 years. She's also a known diabetic, which is well controlled since last 15 years and is on medication for both. She has no allergies or addiction or any known drug reactions. She has no history of recent illnesses, any exposure to anesthesia or surgery. She has no history of trauma or fall from height. Now, coming to the general examination, she is average build, has a height of 160 centimeter and a weight of 62 kgs. She does not have any pallor, icterus, sinuses, clubbing, lymphadenopathy, or bilateral pedal edema. Her pulse is 82 beats per minute, regular and good volume. She has a BP of 128 upon 82 millimeters of mercury right arm in sitting position, and she is afebrile. Now, coming to the systemic examination, her cardiovascular system is within normal range without any murmur. Her respiratory system is also normal. She has bilateral vesicular breath sounds and no added sounds. Her CNS profile is also good with higher functions intact and 15 on 15 GCS, and all her other systems were within the normal functioning range. Now, coming to the airway examination, she has a mouth opening of 3 fingers with a Malampati grade 1 without any artificial dentures and without any signs of difficult mask ventilation or difficult intubation. Now, coming to investigations, all her blood parameters are within normal range, with a hemoglobin of 11.5 gram%. Her RFT and electrolytes are also normal. Her average blood sugar is 176 milligram per deciliter and with an HbA1c of 6.1%. Her viral markers are non-reactive and her ECG, chest X-ray are also normal, with the echo shows grade 1 diastolic dysfunction. Now, so she is diagnosed as a case of bilateral knee osteoarthritis and is planned for total knee replacement, right side followed by the left after 1 month. So the plan of surgery is right-sided total knee replacement.
Okay, Payal, thank you. So, Payal, what is your plan of anesthesia for the surgery?
So, I will proceed with ultrasound-assisted subarachnoid block along with a right modified 4-in-1 block for managing the post-operative analgesia purpose and multimodal analgesia.
Okay, so how are you going to prepare this patient for surgery and anesthesia? What are the
So,
advices which you are going to give to the patient?
So she's a 72-year-old lady with a known diabetic and hypertension since last 10 to 15 years. So during pre anesthetic checkup, I will advise after explaining her regarding the procedure, and after taking proper consent, I will advise her for the proper fasting guidelines, which is a 6 hours for solid meals and 2 hours for clear liquids. Then I will advise her not to take tablet telmisartan 40 milligram, which she is taking for hypertension on the morning of surgery, and I will replace that with a calcium channel blocker, that is tablet amlodipine 5 milligram on the morning of surgery. And also I will ask her to stop taking metformin 1000 milligram she's taking on the morning every day, to stop it on the day of surgery, and get a fasting blood sugar done, as well as serum electrolytes. And also I will ask her to keep 1 pint of PRBC on standby. And
Okay,
also I would like to add, I would advise her to give tablet paracetamol 650 milligram as a mode of preventive analgesia.
okay. So you wheeled in the patient to the OR. So what are the things which you are going to do it?
So after wheeling the patient into the OR, I'll attach all the monitors to her. Then I'll make her sit for the first procedure, that is I'll administer her an ultrasound assisted subarachnoid block, wherein I deposit zero point 0.5 injection levobupivacaine 0.5%, 3.2 ml, along with 15 mics clonidine, by taking help of ultrasound assistance, and then followed by a right modified 4-in-1 block.
Anything, are you not going to load the patient?
Yes, sir.
Preloading?
Yes, sir. I'll check the IV cannula and then go for preloading of the patient after attaching monitors prior to going for spinal anesthesia.
Okay, so you told that you will be doing ultrasound assisted subarachnoid block. So how do you do it?
Okay, so for ultrasound assisted subarachnoid block, we make the patient sit. The positioning of the patient is, the patient is made to sit in a sitting position with the back flexed, and then we choose basically two views are of optimal importance. That is a parasagittal interlaminar view. We would like to achieve a parasagittal interlaminar view in order to identify the level at which we want to inject the drug. And we take a low frequency curvilinear probe and place it longitudinally, and start scanning from chorda to cephalad by identifying the breaks in between the lamina. That is identified, first break is identified as L5S1, and I would like to deposit my drug somewhere in L4, L3, L4 or L4, L5. In case there is any instrumentation or I'm unable to identify the space, I may go up one level higher to L2, L3. And then the second view is transverse interspinous process view, wherein I will need it to check for the midline structures, then to identify the depth from skin till the intrathecal space, as well as the angle at which I would be inserting my spinal needle while injecting the drug.
Okay, so what are the structures which you encounter while putting your needle? What are the structures you pass?
Okay, so I will be crossing through the skin, from skin till the subarachnoid space. I'll first go through the skin, the subcutaneous tissue, the supraspinous ligament, the interspinous ligament, then ligamentum flavum. Then I'll cross over the epidural space to pierce the dura, then the arachnoid, and then I'll land in the subarachnoid space.
So suppose you don't get a good, suppose you are not able to put the needle in the midline. So any other approach of doing a spinal?
So I'll go for a paramedian approach for
Okay.
spinal.
Is it a paramedian? Right now it is called a paramedian or a para. It's almost a para midline. It's almost just slide. So what are the structures we are encountering when you are putting the needle through a paramedian approach?
Okay, so we will encounter almost all the structures that I've mentioned except the supraspinous ligament and the interspinous ligament. So we will go from skin, subcutaneous tissue, then directly we go to the ligamentum flavum, and then proceed ahead by piercing the dura, then arachnoid, and then the subarachnoid space.
Okay, so you did achieve the anesthesia part of the surgery. So what about the post-operative analgesia? So what are the blocks which you can use in this patient for a total knee replacement for a post-operative analgesia?
So for post-operative analgesia, we have various options, starting from neuraxial, which is not routinely practiced nowadays. We can have an indwelling epidural catheter. And coming away from neuraxis, the non-neuraxial procedure, we have various extra-articular options and intra-articular options. Now, targeting the extra-articular options, we have various blocks such as the femoral nerve block, then the distal femoral triangle block, then we have the adductor canal block. And then coming to the various intra-articular options, we have the IPAC, then LIA, and selective tibial nerve block. But however, to achieve an optimal analgesia, we need to combine these two, the extra-articular option and the intra-articular option. So we have various motor involving blocks and motor sparing blocks. Now for motor involving blocks, like we have, or the non-motor sparing blocks, we have femoral nerve block plus selective tibial nerve block. And then in motor sparing categories, we have various blocks such as distal femoral triangle block plus an IPAC, or we can go for adductor canal block plus an IPAC block. Then we can go for modified 4-in-1 as well as a dual subsartorial block. Also, we have various genicular nerve blocks which we can use as an add-on to these blocks to achieve a optimal analgesia.
So why did you use these block options? Because what are the tissues which are disrupted during a total knee replacement, and what are the relevant innovations? Obviously, you have told the blocks. So why you need these types of block? What is the disruption of the tissue and the innovations of those surgical disruption area?
So the knee joint is very has a very complex innovation, and for a total knee arthroplasty case, in majority of the scenarios, the surgeons use a median parapatellar arthrotomy incision, wherein they cross over through the extra-articular structures and then proceed towards the various intra-articular structures. Now, coming to the extra-articular structures which they cut through are the skin, the subcutaneous tissue, as well as the medial retinacular complex. Now, supplying these extra-articular structures are the medial femoral cutaneous branch of saphenous nerve, then the infrapatellar branch of saphenous nerve, and the medial retinacular nerve, which is the terminal branch of nerve to vastus medialis. Now coming to the various intra-articular structures which we encounter, all the nociceptive generators, those are the various collateral ligaments, the menisci, the infrapatellar pad of fat, and all these are supplied by the popliteal plexus, which includes the posterior division, articular branch of the posterior division of obturator nerve and the articular branch of the tibial nerve. So basically, we need to for achieving an optimal analgesia, we need to target 4 major nerves, which is the saphenous nerve, then the nerve to vastus medialis, then the popliteal plexus, which includes the articular branch of posterior division of obturator and articular branch of tibial nerve.
So you told about the patellar part of fat, the collateral ligaments. Are they remaining after TKR
No,
surgery?
sir. No, sir. The entire
So what intra-articular part you want to take care?
so
What
the cut
intra-articular?
ends of the the bone ends which are cut, those the periosteum, those have the nociceptors in them,
And
and
what is remaining inside?
the
What remains inside?
synovial, the
Anything
capsule,
posterior capsule.
posterior capsule.
Because what you told, those have nociceptors, but obviously those are removed when the TKR, when they rim and everything, and what remains is the implant and the posterior capsule and few cut ends. Okay. So you told about the different blocks. So, why you went for your how you differentiate whether it's a sonoanatomically, how do you talked about distal femoral triangle block, the adductor canal block. So sonoanatomically, how will you know that you are in the distal femoral triangle or adductor canal?
Okay. Here we have to identify the apex of the femoral triangle, which is a major landmark. Now, how will we identify the apex? The apex is identified as the meeting point of the medial border of sartorius and the medial border of adductor longus. Now, that is identified as the apex of the femoral triangle and as well as the starting point of the adductor canal. So, proximal to that point or proximal to the apex of the femoral triangle lies the distal femoral triangle part, and distal to the apex of the femoral triangle lies the adductor canal, which extends up to the hiatus adductor hiatus. That is the entire adductor canal, which is again further divided into proximal, mid, and distal.
So what is adductor hiatus?
So adductor hiatus is the end of the adductor canal, wherein the saphenous nerve as well as the superficial femoral artery that it enters continues as the popliteal artery.
Okay. Can you say where the distal femoral triangle starts? Can you identify it sonoanatomically?
Yes, sir. We can identify the okay. So the entire femoral triangle is divided into iliopectineal fossa, which is the boundaries are by the medial border. Laterally, it is bounded by the medial border of sartorius and medially by the lateral border of adductor longus. Now, the meeting point of these two is identified as the apex of the iliopectineal fossa. Now, beyond that point, till the apex of the femoral triangle, as described earlier, lies the distal femoral triangle, and beyond, like proximal to it, is the iliopectineal fossa, which is again divided into proximal and distal iliopectineal fossa.
Okay. What are the regarding the adductor canal? Okay. So the nerve to vastus, you told that nerve to vastus medialis is very important. Okay. So suppose I say you give a proximal adductor canal. What are the contents of adductor canal? You talked about the adductor canal. What are the contents of adductor canal?
So the contents are superficial femoral artery and a vein, as well as saphenous nerve. And the nerve to vastus medialis is not considered as a content because it lies in a separate facial compartment, which we can identify by using PNS or otherwise. But it is not a part of the adductor canal proper.
So how do you identify the nerve to vastus medialis by a PNS?
Sir, we keep our probe in the anteromedial aspect of the thigh, and then start scanning from the apex of the femoral triangle.
I am asking, what is the response you are going to see when that this is a nerve to vastus medialis? What response you will see?
So at 0.4 to 0.5 milliampere current, stimulating current, when we will see a muscular twitch or contraction of the vastus medialis muscle. That is the motor endpoint.
So you told about the combination of the block. Yes. Why do you told that you will combine a adductor canal with a IPAC and a femoral triangle with a IPAC? Why you want to combine it?
So because to achieve an optimal analgesia, we need both the extraarticular as well as the intraarticular structures covered. The proximal adductor canal will provide only pain relief for the extraarticular structures, whereas IPAC, which is infiltration of local anesthesia between the popliteal artery and the capsule of the knee, will take care of the popliteal plexus group, which supplies the intraarticular structures. Hence, both will be covered, and we can achieve a optimal post-op analgesia.
So you talked about so many approaches. So what are the advantage and disadvantage of the different approaches?
So basically, the site of injection as well as the volume of the drug where we are depositing, it is important. And two parameters we need to keep in mind while planning for a post-op analgesia for a TKR is basically to achieve adequate analgesia and early mobilization of the patient, which is required post-operatively. So if we go more proximal in our approach, then we will achieve a very good analgesia, a very dense block. However, the motor sparing will not be there and the mobilization will be totally compromised. However, we can block all the cutaneous innervations like the medial femoral cutaneous nerve, the intermediate cutaneous branches and everything by going more proximal. However, if we go more distally, we will achieve a good analgesia, but also the patient can be mobilized early and go for early physiotherapy post-operatively, which is our target according to various protocols.
So, so basically, how do you assess the quadriceps strength? You told about mobilization. For
Yes.
walking, do you can walk even if you have a quadriceps weakness because you require the hip muscles.
Hip
So
muscle.
how do you assess the quadriceps strength?
Okay. So we have few tests. There is a dynamometric analysis wherein we do a time to get up and go test and a 30 seconds chair test. I cannot elaborate both, but
Okay, fine.
yeah, just read the
Okay,
names.
fine. So now, what is the prospect guideline for a TKR? What are the content? What are there in the prospect guideline for a TKR?
Okay. So, prospect basically stands for procedure specific guidelines for post-operative pain management, and they lay down few recommendations for pre-operative, intraoperative, as well as post-operative analgesia protocols. Now, in pre-operative and intraoperative protocols for TKR, prospect lays down the use of IV paracetamol along with NSAIDs or COX-2 inhibitors where they are not contraindicated, like patients with bleeding duodenal ulcers or patients with asthma and all, we cannot give them NSAIDs. So we can give only IV paracetamol. Along with it, for regional analgesia techniques, Prospect recommends a single shot adductor canal block or LIA or a combination of both. And then Prospect also recommends intrathecal morphine. 100 mics can be given in cases only where the adductor canal block or LIA cannot be performed due to various reasons. And then IV dexamethasone is recommended. Then these are intraoperative protocols. Now for postoperative protocols, similarly IV paracetamol is recommended, NSAIDs is recommended where there is no contraindications, and opioids are recommended only as rescue analgesics. So Prospect does not recommend epidural, does not recommend gabapentinoids, ketamine, fentanyl usage and all, and also no femoral blocks and no sciatic nerve block.
Okay. Have you heard about IRAS protocol for the for the joint surgeries? Right now, you have IRAS protocol for your TKR, THR. So, what is there in the IRAS protocol?
Okay, so IRAS stands for Enhanced Recovery After Surgery. They have various grades of recommendations and levels of evidences. According to that, they have formulated various guidelines for pre-operative, intraoperative, as well as post-operative protocols. So now coming to the pre-operative protocols for case of TKR. Proper counseling of the patient during PACs and consent is to be taken. Optimization of the patient is to be done. Then proper fasting guidelines, that is 6 hours for solid meals and 2 hours for clear liquids. And for enteral surgeries, okay, I'll not go into enteral surgeries. Okay, then next is there is a weak recommendation for mild sedation and anxiolysis. Now coming to intraoperative protocol proper choice of anesthesia, it is recommended as modern day general anesthesia or neuraxial anesthesia, which only meets intrathecal anesthesia or spinal block. No epidural is recommended. Then for regional post-operative regional analgesia protocol, adductor canal blocks and LIA. Then for multimodal analgesia, we are having paracetamol, IV paracetamol, then NSAIDs and COX-2 inhibitors where there is no contraindication. These are all strong recommendations. Then for post-operative nausea, vomiting prophylaxis, we have IV dexamethasone. Then for intraoperative bleeding, like decrease the risk of intraoperative bleeding, we have tranexamic acid. Then there is a antimicrobial prophylaxis. Then there is a antithrombotic prophylaxis to curb post-op DVT chances. Then there are specific guidelines for surgical faculties, which are they do not have any strong recommendations for placement of catheters or drains or tourniquet in that. Then coming to post-operative protocols, they have early mobilization, early enteral feeding, and for analgesia purpose, again IV paracetamol and opioid-free multimodal analgesia.
So what feeding advice post-operative? How early you allow your patient to feed? You told about the RAS protocol. So how you practice?
Sir, after we keep the patient NPO for 2 hours for liquid, then after that we can allow clear, like because we have given some mild sedation also intraoperatively if the patient is anxious and all, or the patient requires put me down to sleep, I don't want to go through the surgery like that, so we might give the patient few mild sedative, so till the effect gets relieved, we keep the patient. So as an institutional protocol, we keep the patient NPO for around 2 hours for clear liquids, then we allow the patient to take liquids, and then subsequently semi-solid diet,
Okay.
and after 4 hours. Yeah.
Okay. So your patient was a diabetic patient, right?
Yes,
So
15
yeah. So do you want to be careful about the regional analgesia, the blocks, nerve blocks, and everything which you gave? So is there any things which you have to take care as a in a nerve block with a patient with diabetes?
Yes, sir. My patient is a known type 2 diabetic since last 15 years. So I'm like while doing PAC, she might have like I guess that she might have developed its microvascular or macrovascular complications as well. So during PAC, I asked her regarding the presence of any pre-existing neuropathies and all, because that I have to document it, because I am planning for a post-operative analgesia. I am planning for a regional block, so I should keep that in mind, and I have documented it, which she has replied in negative. But in patients who have already developed diabetic neuropathy, the nerves are already irreversibly damaged. So while using any peripheral nerve block and the LAs, I have to be very careful regarding the concentration of the drug, and also regarding the concentration of the drug, and also regard, since the diabetic neuropathic nerves tend to get blocked for a prolonged period of time, I will also be aware not to use adjuvants for them, and I will also avoid using vasoconstrictors along with LAs, because they will further damage the pre-existing already damaged nerves. There will be an ischemic insult, and they might land up in something like a double crush injury. And I should be very careful while navigating my needle under an ultrasound guidance, so that I do not directly hit the nerve or do a direct needle trauma to the nerve. And also in those patients, actually the diabetic neuropathic nerves have a very increased Rio base. So because of that, they require very high stimulating current in order to get stimulated. So wherein for a normal nerve, if we get stimulate around the 0.5 or 0.4 milliamperes, in diabetic neuropathic nerves, it might go up to 2.5 or 3 milliamperes, which is very high, and that might cause further damage. So it is always better to use it is preferable to use a ultrasound guided block rather than a PNS guided block. And also for perineural catheter placement, it is not advisable because they are more prone for infections and all, and I have to maintain a strict asepsis while conducting the block and clearing the area prior to performing a block.
So you yeah, yes, last question,
Yeah.
Ahmed. Yeah,
Okay.
I'm almost done. So you have done fantastic. You gave a fantastic anesthesia. You gave a fantastic block. Okay, and your patient cries in pain at midnight. Okay, so what is that? What is that? Mane, your whole thing was gone. Your patient cried in pain. So what pain he had?
We can expect like the patient might be having a rebound pain
Yeah, just be short
because
because we have time up.
okay.
Just so what is the rebound pain?
Because
What is the rebound
so
pain?
rebound pain is an acute transient post-operative pain which occurs after the dissolution of the peripheral after the dissolution of the effect of the peripheral nerve blockade in an environment of depleted systemic analgesics. If I have not been able to cover her systemic analgesia protocol properly in the multimodal analgesia, then she might have pain after the effect of the single shot modified 4 in 1 which I
So
have given.
so how will you take care of that rebound pain?
Sir, proper multimodal analgesia protocol has to be followed with round the clock coverage. Then, while giving the drug, I would like to add an adjuvants to it so that
Which
the effect will
adjuvant?
be prolonged.
Which adjuvant has less rebound pain?
So, dexamethasone perineural is added,
Okay.
uh, particularly targeting the rebound
Okay.
pain aspect.
Okay. Thank you,
And
Dr. Payal. Thank you very much. Thank you. It was very
Thank you.
nicely answered. Thank you very much. Thank you,
thank
Amit.
you.
So thank you. Very nice. I think we all enjoyed the deliberation. Now, moving on to our next session,
Thank you.
we have, thank you, Payal and Ritesh.